tonight's Lupus and You webinar. I'm Amy Yalden, CEO of the Lupus Foundation of America's Florida chapter. And I want to thank you all for joining us tonight. And I want to thank our partner in tonight's event, Aurinia. Each month, we present webinars on important topics related to lupus from experts across the country. Tonight, we'll be discovering a different treatment option for lupus nephritis. And before I introduce you to tonight's host, I wanted to remind you that the information provided in this webinar is for general informational purposes, and it's not a substitute for your physician's advice. The views expressed by our webinar presenters are those of the presenters and not necessarily those of Lupus Foundation of America. If you have any questions during this webinar, please type them in the chat box and our presenter will try and answer as many questions as possible. And if you have any further questions or want to learn more about upcoming educational programs, support groups, or events in your area, please reach out to us. We'll be sure to put our contact information in the chat room. We will be recording tonight's session so you and others can view it later. Please remember to keep your audio on mute so that everyone can hear the speakers. Now I have the pleasure of introducing our host tonight, Stephen Burnett, the Regional Professional Relations Lead at Aurinia for the Southeast, and who's also responsible for patient advocacy and education. I will turn this over now to Stephen. Thank you again so much for being here tonight.
Thank you, Amy. I appreciate it. And good evening, everyone. I'd like to welcome you all to today's virtual discussion, Bringing the Fight to Lupus Nephritis. It is sponsored by Aurinia. Again, please make sure that you keep your lines muted and video turned off throughout the presentation to limit any potential distractions for the presenter. Today, we are going to talk about lupus nephritis and discover a treatment option to help bring the fight to people living with active lupus nephritis. And before we get into this treatment option, we're going to be hearing a great story from one of our speakers this evening, the young lady named Judith. And so just to bring you up to speed, Judith is not on Aurinia treatment. She's not affiliated with Aurinia Patient Support Program. However, she is being compensated by Aurinia for her time today. She is here today to share with you her lupus nephritis journey. So if you have any questions for Judith throughout her presentation, again, as Amy mentioned, please type it into the chat box at the bottom of your screen. It is my pleasure. Thank you, Judith, for being here today to share your lupus nephritis journey. The floor is yours. You may begin.
Hello, my video is disabled. I'm not able to open up the video. Thank you for giving me the opportunity to share my journey. I went from running track to not being able to walk up the stairs at school. A leather jacket I got for my birthday the year before became too heavy for me to wear. I also had to deal with my peers constantly criticizing me of being pretentious, that there was nothing wrong with me, that I'm just lazy, and that I was always hurt and I couldn't practice. I mean, I looked like a picture of health. At a point in time, I thought I was imagining things. My mom listened to every complaint and took me to the doctor's offices quite often. 2 years of suffering from anemia, hair loss, extreme fatigue, and loss of appetite. My doctors didn't have an answer. The doctor associated the hair loss and loss of appetite with anemia, and fatigue with the fact that I was a track runner and also a dancer. So he told me I needed to give, one of them a break, and I quit dancing, but I kept pursuing my dream of track and field because I wanted to break records. I had a dream of being the next FloJo, but things didn't get better. In October 1999, on Halloween, I ended up in the ER with a hemoglobin of 4 and dehydrated. What a coincidence, Halloween and, my hemoglobin being at 4, I'm like, okay, the vampires came from my blood. Right away, the doctors called me the walking dead. They wanted me to do a blood transfusion, but my mom said no, because we wanted to know what was wrong with me. We wanted a diagnosis. After 5 days, of being in the hospital. They ran all the tests that they could, and they sent me home and basically told my mom to make me comfortable. I walked into the ER and left the hospital in a wheelchair. 2 days after being at home, they called back and they said, we have 2 more tests to run, lupus and HIV. At the time, it was very difficult to even get blood out of my veins. I have very tiny veins. I agreed because at the time, one of the nurses got stuck with my needle. By this time, I'm developing rashes all over my body, but I didn't have the typical butterfly rash on my face. So I agreed to get the blood work done. A day or so later, they called me back and they said, it's lupus. I was quite relieved because for a long time, I thought I was crazy with all the symptoms that I was experiencing and being told that there's nothing wrong with me. So I thought that, this was the end of it, give me some Tylenol and I'll just go back to my life. But that's when the true journey began, dealing with side effects and physical changes. While that was happening, I entered into college where, I was being criticized there for being antisocial and not being involved in all the campus parties. And, I was told I was weird. I was a part of a leadership group on campus, so I decided to use that as a teaching moment to raise awareness for lupus. I got everyone from, student government organizations to wash cars and sell candy and bake sales. And we raised money for the local chapter in New Jersey, Lupus Foundation of America. I ended up on the newspaper, a Sunday newspaper, the Record and the Herald News, talking about lupus, the silent killer. While all this was happening, an advocate was born. And I also saw myself advocating for invisible disabilities because, you look like a picture of health when it comes to lupus. In the midst of that, I'm also juggling trying to make the grade. And I was experiencing new symptoms, but I just associated with the fact that, it's just lupus. I was having swollen ankles, swollen feet. I basically associated that with the fact that, I walk around the campus at Montclair State. And my mom even made fun of it, saying, as a child, I've always had fat feet. But the doctor kept talking about spilling enough protein, which I didn't really take the time to ask him, or did he also take the time to explain to me exactly what was happening? Because my main concern was passing my classes. I also started experiencing frequent urination at night. I associated that with the fact that I drank a lot of fluids. But things was getting worse. One semester after finals, I just couldn't take it anymore. I basically pushed through just so I can make it through my finals. I was getting heavy chest pains. It was hard to breathe. And, I ended up in the ER and they told me my kidneys were shutting down. My potassium levels were high. I had fluid in the lungs, scary things, but I put on a brave face because I didn't want my mom to, break down. Even though I was going through it, she was living it with me, having an only child who's always sick. So I put on a brave face and just hope that things would get better. A few days later, they said to me, oh, we know what's causing those symptoms, like some of the medications that I was on. So I was sent back from the hospital to go home with more treatments. I call it the notorious P. And I thought things would get better, but the doctor still kept insisting that I was spilling protein over a year later, and that I needed to see a nephrologist. I agreed. And the first thing the nephrologist said, in order to begin treatment, I would need to do a biopsy. And I said, biopsy. The first thing that came to mind is scars because, lupus is quite a scarring disease. I've already been through surgeries where there's very visible scars. Even though I was learning to accept them, I didn't want any more. And the doctor told me that I would be fine, and it's a simple procedure. And can you imagine being chronically ill and vain? Yeah, that was me. I agreed, and we got the testing done, and I got the diagnosis of lupus nephritis. The first thing that came to mind is, am I going to lose my kidney? Second thing was, do I need to be on dialysis? You know, frightening things for, you know, a young lady in college. But luckily, with all those treatments that I went through, my kidney was able to be saved. And this is one of the reasons I share my story with lupus nephritis, so that people can pay attention to the signs and symptoms and not to ignore them, and, you know, ask for answers when, you know, you go into the doctor's office and they're telling you these things. Don't ignore them, because your health is more important. At the time, I was so into my grades, you know, just trying to pass classes, that I ignored a lot of red flags. So I share my story so that patients who are going through, you know, similar symptoms, and, you know, don't take it very serious. They shouldn't take it lightly. I also share my story to be a beacon of hope, because I want people to understand that being diagnosed with lupus nephritis is not a death sentence. You can live a productive life. It's going to be roller coasters, but that's what life is about. And you can make it through no matter what your situation is. And I use my story as an example, not just in the lupus community, but in the classroom where, you know, I teach. I lecture biology and other course subjects. And, you know, I see students going through so many, you know, different challenges. And I use myself as an example that you shouldn't allow, you know, things to, you know, change your perception of life, that you can change things around your mindset, and show, and, you know, share my story with them. And, you know, I'm very grateful to be here today to share my story. And especially for the new people who are dealing with this diagnosis. But at the time that I was diagnosed, there weren't so many therapies. And Arena has been one of the companies that, you know, is giving us hope, because all we've all asked for is better treatment until we find a cure. Thank you for having me.
Thank you so much, Judith, for sharing your journey with lupus nephritis. As a reminder, if you have some questions for Judith, you can please type them in the chat box at the bottom of your screen. Please keep your questions general in nature and not refer to any specific questions about your health or your specific treatments. Any questions you have around those should be directed to your personal health care team. Again, if you have questions for Judith, please type them in the chat box below. We'll hold a few moments to compile any questions we may have. This time, I am not seeing any questions. Okay, then we will move on to our next presenter and speaker for the evening. It is really my pleasure and honor to introduce you to our next speaker, Dr. Gail Carr. She is a rheumatologist. Dr. Carr is the Chief of Rheumatology in the Division of Rheumatology and a Professor of Medicine at Howard University in Washington, D.C. She is also a professor at the Howard University College of Medicine. Dr. Carr, you may begin when you are ready.
Thank you very much, Mr. Burnett, and I want to thank the Lupus Foundation of Florida for hosting myself and most especially Judith to share her very impactful story with us, components of which I am sure is shared by many of you joining us today. What we would like to do today on behalf of Arinia, who has sponsored this event, is to share with you new information that you will find useful in your discussions with your physicians when you go to discuss your involvement of lupus and the kidney and your options for therapy. And that's because we have now a first and only oral therapy for the treatment of lupus that's been recently approved. The name of it is called Lupkynis, and we'll hear more about this as we go forward. One of the first things you do, and we have access to the internet now to clear up these things, is to find out whether the drug will cause you harm. That's one of the first things you look at. And you often look at what's called the PI, the package insert. And one of the things, the two words you'll come across, one is contraindication and limitation. And the contraindication really indicates that we know that if you take it in combination with other agent scenarios, that it's likely to cause harm to you. Limitation is where we don't have evidence of therapy that's given with the Lupkynis, and therefore it is not recommended because we don't have the data to support it. In addition to that, because this is an immunosuppressive agent, and because lupus is an immune disease mediated, the therapy is aimed at actually trying to reset or rein in the immune system that has gone awry, it's slipped off the rails. And part of that immunosuppressive therapy, the risks are development of potential cancer, such as cancer of the lymph nodes, lymphoma, or of the skin. And we ask, therefore, as you would do anyway for lupus, to protect your skin when you go into the sunlight with wearing long sleeves and having adequate sunscreen. One of the other side effects of immunosuppressive therapies of any kind used in lupus is that of increased risk of infections. So both you and your physicians have to be vigilant. You have to be on the lookout for any signs of infection, such as fever, sweats, a cough, any soreness or redness of the skin to indicate that there's inflammation, infection in the skin, such as cellulitis, so that you can be appropriately evaluated to have appropriate therapy. You should not take the drug in combination with grapefruit juice. That may increase the risk of having side effects for the drug because it may reduce the metabolism, the breakdown of the drug, as do other drugs that share a pathway of certain enzymes called CYP3A4. And those are some of the fungal medicines like itraconazole, ketoconazole, and some antibiotics. We're in the era of vaccinations. It's all the talk, COVID included, and we like to protect our lupus patients from having infections that are preventable. But like many of the therapies, you should not take any immunosuppressive therapies with live vaccines, such as measles, mumps, rubella, traveling to places that require a yellow fever vaccine. Those are live viruses, and you really shouldn't take those with this drug. And any other vaccines, you need to discuss with your physician the timing and appropriateness of those vaccinations for you. You should also have a discussion if you have significant comorbidities, such as heart disease, liver disease, and even the kidney, which we're going to focus on. You have to discuss with your physician components of that renal impairment, which may cause you to consider taking or not taking the drug, as would a very high blood pressure that needs to be controlled. None of the data we present was ever conducted in pregnant or breastfeeding individuals, and therefore we can't give advice about that. We can only know what's reported after the drug is approved. So those discussions, again, you have to have with your physician. Very important to have the knowledge from what we present today, what you read hereafter, and have discussions with your physicians. So let's understand the disease itself. So as Judith indicated, it occurs in patients who have lupus. It happened in her, and it's not that uncommon, but it's serious enough for us to want to detect early and to really have aggressive intervention so that we can prevent permanent damage. Because once it occurs, it is irreversible. It is said that once we detect kidney involvement in a lupus patient, you already have lost some of its function. So the whole aim is to preserve what is left. And every time you flare with the disease, you have additional scarring and less function. So we want to preserve the disease, the remaining function in the kidney once we detect that there is inflammation, because otherwise we're going to be left with impaired renal function, chronic kidney disease, chance of kidney failure, requiring dialysis, and ultimately patients going on to need a transplant. And this is a risk that can occur in as many as 30% of individuals. It is not uncommon, maybe about 45% will have some degree of lupus involvement. The degree of involvement varies from patient to patient. It's more common in the patients I see, African Americans, but also Asians, fourfold, and also twice as common in patients I see also, Hispanics and Native Americans, all these in comparisons to Caucasian individuals. Judith outlined some of the symptoms and signs that she had. She had swelling in the ankles and feet. And if you take your finger and press into that swelling, it will leave a mark of the edema. All of us should have blood pressure cuffs at home. And if you're a lupus patient, it would be good after you're relaxed to do your monitoring each daily and share this with your physician, whether your primary care, your rheumatologist. And if you note that your blood pressure is creeping upwards, you need to be aware and vigilant and call in, go and see the rheumatologist. Urination is frequent, occurring at night, and when you look into the bowl, it tends to be foamy and frothy. These are indications that the kidney could be inflamed and is leaking more protein than it should. You go to the doctor, and what does he do? In the office, they will do tests, examinations there, looking to see if you have evidence of blood in the urine, hematuria, or protein in the urine, proteinuria. And they have in the office usually a stick which they dip into the urine, a dipstick, and can detect the degree of proteinuria. And it's usually referred to as 1+, 2+, 3+, or more. But it would be prudent, wise, safe for us to have a number instead of those readings, because there are individuals or instances where a 1+ could indicate that there's more protein in the urine than there should be, more than the 0.5 milligrams, which is the number. That's the magical number you need to be below for us to have control of disease. And that 1+, you may in fact have more than that 500 milligrams or 0.5 grams in the urine. So we need to measure your urine. How frequently? You should be doing that every 3 months. That's a recommendation from the experts for us to detect early and institute therapy once it's detected. So we do those tests on the urine, looking for protein and blood, and then he orders some blood tests to see how you're filtering out the function of the kidney, your serum creatinine. And that tells us whether there's any creep in the function or the filtration of the kidney with the GFR, glomerular filtration rate. That's important. And if these all combined indicate that something is brewing, there's inflammation here, you're spilling protein, there's blood in the urine, the next step is to get a picture of that inflammation with a biopsy. Judith mentioned her fear of scarring, but this is rather routine, well managed now by interventional radiologists, and they go in and take a piece of the kidney. There is no physical scarring whatsoever, but the information we get is crucial. It tells us the extent of inflammation, the severity, and therefore we have a visual of the disease that we're trying to treat. So we tend to have severe consequences if we don't detect this very early. It can damage the kidney. You have increased blood pressure. That in itself can go ahead and start punching the kidney in addition to the inflammation of the lupus. And we go on to have chronic failure, end-stage kidney disease, permanent scarring. And while this is happening, this damage is happening, it also brings along damage in other organs. You also suffer damage in the heart, and you can have damage in the brain. And the risk there is increased incidence of heart attacks, increased incidence of stroke if we don't detect the inflammation in the kidney, lupus nephritis, and if we don't start to treat this entity. Many of you have at some point received steroids, and many of you have at some point received high-dose steroids. And we all use this to try and get control quickly of any disease you have, included in the kidney. But we all know the side effects, and you do too. It causes increased blood pressure itself, something we're trying to avoid by not having the kidney fail. It causes elevation in blood glucose, lipids, obesity is one thing very hard to control when we stop the drug to try to lose that weight. And it can cause loss of bone texture, density, and you can have osteopenia, osteoporosis, and go on to have fractures very easily. And also cataracts in the eye. So we try to minimize as much as possible the dose, the high dose and duration of prednisone. But when you have renal involvement, we start out usually with high doses. How much damage you can have from this, or how much prednisone you should try and stay below to avoid this damage. If you ask a rheumatologist how much they're happy with prednisone dose of a patient, the answer is really zero. We would like not to have long-term use of steroids. But giving you an idea, anything over 7 we consider high. Anything over 7 gives you all the risk of that list of side effects I gave you. And your risk of having new organ damage, heart, brain, and the kidney itself really escalates with each milligram of prednisone that you use. So if you're on 10 milligrams, you have 30% increased risk of damage. So keep that in mind, that that's our aim, to have better control of disease, put things into remission, and therefore decrease the dose of prednisone or eliminate it altogether. So the therapies we want are those that can reduce inflammation to help stop the attack on the kidneys and prevent it deteriorating into chronic kidney disease, renal failure requiring interventions of dialysis and transplant. So what is Lupus? Well, it helps us to control this inflammation. It gets the lupus nephritis under control because that's the only thing it was studied in. We don't use it in combination with cyclophosphamide, but it was used in combination with mycophenolate mofetil, in addition to steroids. Many of you know this as Cellcept, and it's shown to work without needing that high dose of steroids over long periods of time. And most importantly, got to the thing we're trying to reduce, the protein in the urine, much faster than you would with the mycophenolate, MMF, and steroids alone. So that's the advantage of this new approval. So with this knowledge, you can have a discussion with your physician. You know it's common and serious. You want to avoid it by going in every 3 months to have my regular testing of my urine and knowing what your number is. You want to also have blood tests to go along with them to know what your filtration rate is or your serum creatinine. You want to be on top of your blood pressure. And if you are spilling protein, you want to say to your physician, what are my treatment options? Do I go on mycophenolate and steroids? And when do I add lupus to this so I can preserve renal function? So discovering the treatment with lupus. Again, this is oral. Many of our new therapies are actually infusions or injectables. And we got to this point of knowing what it can do by having clinical trials. All the drugs that we write prescriptions for, there were individuals with diseases who said, yes, let me try and help find new therapies by participating in these clinical trials. And this is what we found, that we could protect the kidneys from damage without high dose of steroids. It does it in 2 ways. by changing the immune system, suppressing it so that you don't have as much activation of the immune system to cause damage. And then there are components in the architecture of the kidney that it changes in the tubules so that they minimize the loss of the proteinuria. So it does two things, immune system and actual structure of kidney, both of those resulting in less proteinuria. How did they get these data? And you often see when physicians talk to you about the studies show, often you think, did those patients look like me? Well, I think they did a good job in the 350 patients there. They had men, not many of them have lupus, but when they do nephritis, it's much more severe, but also women, who is by far the majority who have this. They had African Americans, they had Asians, they had Hispanics involved. The spectrum of diseases of individuals I see with lupus nephritis, and also the spectrum of ethnicities who tend to have more prevalence of this entity, lupus nephritis. The studies showed the following, that it helped get the lupus nephritis under control, it worked without high dose of steroids, and it reduced the proteinuria, the protein in the urine, all as part of a treatment plan that included lupus in addition to the mycophenolate and the steroids, not lupus alone. And we were aiming for a number of less than 500 milligrams of protein in the urine, or 0.5 milligrams per day. We also found that the patients on this combination of lupus and mycophenolate and the steroids, they were able to get their disease under control 3 times more than the patients who didn't have the addition of the lupus to their mycophenolate and steroids. So on that additional lupus, you have a greater chance of getting into control. And it also was able to do this with a lower dose of steroids, the lupus in addition to the mycophenolate and the steroids. How much faster was it able to do this? Well, the conventional therapies before this was approved is where we would use the mycophenolate, MMF, and steroids in patients. And we'd often have to wait as long as a year to get control or reduction in the protein in the urine, 1 year. In this trial design where they added the lupus to the MMF and steroids, they were able to get that proteinuria down in half the period, in 6 months. And studies have shown that the faster you can get that protein down, the more you can preserve renal function. So this was a great advantage of this trial, of this drug, and this finding. And how quickly you could get at least half a reduction of your starting level of proteinuria, you got this down in about 30 days, a month. So if you had 2 grams, some people have even higher. But let's say a patient has 2 grams proteinuria within a month, they on average saw that they could reduce this by 50%. It got to 1 gram, but it was still not the target where we all need to go and aim for, and that is the 500 milligrams a day or 0.5 grams a day. So what you need to know is remember that there are limitations to what it's given with. We don't know about cyclophosphamide, and that's usually used intravenously sometimes to treat lupus nephritis. Not recommended, was not studied. We have no data on pregnancy and breastfeeding. Know the drugs that you should avoid. So always walk with your medication list, and if they're too difficult to spell, take all the medicines in the bag with you so the doctor sees which ones you're on so that the lupus can be safely prescribed. And of course, if you're allergic to any components in the lupus, the physician will review that. Serious side effects. The other question you always ask, what side effects will I have? And you have to report every single thing that the patients report during this trial. These were the more common ones. Diarrhea, which often abated over time. Some had headache, cough, urinary tract infection, stomach pain, heartburn, or some alopecia, loss of hair. If you experience any of these problems, plus any worsening kidney issues, if your blood pressure readings are higher, we need to discuss that with the physician. Is it something else? Is it the kidney disease? Is it the lupus? Do they need to adjust therapies? Very important. Any nerve system involvements, confusion, you're not thinking right, numbness. Is it the disease or is it the therapy? We have to have regular labs on you to check the function of the kidney, but also to check potassium. Judith mentioned that when her kidneys were not working, the potassium gets high. We need to know that with lupus as well. Any chest pain and palpitations, EKG needs to be done, and they do basic special measurements in those waves to find out if you're at risk of having any complications. And the blood counts are also monitored, as we do for many of our immunosuppressive agents that we use to treat lupus and lupus nephritis. So you know now more about this entity. You know the importance of identifying early and stopping the attack on the kidney in order to preserve it. And here we have a way of minimizing the amount of steroids that you have to take and the duration of it. So what to know about taking this drug? Well, we know that it was studied only in combination with the mycophenolate and steroids, and that it was prescribed only for lupus nephritis. It wasn't studied for other components of lupus, skin, etc., only with the kidney. It's taken by mouth, not injection, and the standard dose is 3 capsules taken twice a day. And I can see everyone's doing, oh, no more pills. And I agree. Patients with lupus, because it affects so many parts of the body, often require multiple medicines. But maybe we need to consider this. If I'm to preserve my kidneys, the organ that filters the toxins from my body, and have a chance of preserving the function without going on dialysis, having chronic renal disease, and have to be put on a transplant list for 6 extra pills a day, something to consider. If I'm to take 6 extra pills a day to reduce the amount of prednisone I take so that the side effects of those are less, something else to consider. And that high dose of prednisone, which pushes up my blood sugar, additional therapy, can also push up my blood pressure too, additional therapy, maybe push up my lipids, additional therapy. Then if I can minimize all of the side effects of prednisone and maybe put those additional therapies at bay, it may be worth the additional 6 tablets a day. And the dosage remains the same. It's always those 3 capsules twice a day, requiring monitoring by your physician to make sure that it's working and that it's safe. It's to be taken on an empty stomach, 12 hours apart. So the early birds amongst us, the 6 o'clock wakers, will do it 6 in the morning and 6 in the evening. Those who go to bed late will have it 11 at night, 11 in the morning. Say I wake up at 6 and I'm busy getting the kids out and I forget to take it. Can I catch up? Well, you can, but not if it's after 10 o'clock in the morning if you're a 6 o'clock person. No more 4 hours past your usual dose. Never double dose. Just miss it, chart it as a missing dose, and pick up with the next dose that you were to take that evening. Never break, crush, or chew it. Just swallow as you need, and always take it as we recommend, okay? Just take the 3 tablets twice a day. Because we have multiple meds, we tend to have medication packages for our medicines to keep us on cue, regular with our meds. But here's a difference with lupus. It's given in a blister packet, which keeps it safe temperature, safe conditions, so it maintains its integrity. But it's also good to make you be sure that you took it, because once you blister and take, it's out and you know that you took it for that day. So make sure you understand the safety of the capsules too. Stay on track. Stay up to date with your doctor's appointments. Judith mentioned her family situation with her mom, having to also think about somebody else, not only looking after them, but the impact of your illness on them. We know what that is like. Sometimes doctor's appointments become difficult. We know what that's like because an unexpected babysitter or something, some situation. But now we have other ways of maintaining contact. The COVID taught us that. We have telehealth. Stay in touch, never lose touch. Make a video call if you can't come face to face. We can get labs done. We can look at you. We can look at the edema. We can measure. You can measure your blood pressure, give us a recording, and maybe even come in with your blood pressure cuff to make sure we're on cue. Nothing, however, replaces your face-to-face in-office visits with your physicians, but maintain contact and tell your doctor if you're having any symptoms. Always have those regular tests, the measuring of the protein in the urine, the blood in the protein, looking at your filtration rate, your creatinine levels, and all your other counts to make sure you're tolerating the medication well. I'm going to hand it over back to Stephen to tell you more about what Aurinia can do for you as well.
Thank you, Dr. Carr. Yes, Dr. Carr mentioned, we do have internal group called Aurinia Alliance, and it's a program specifically for people living with lupus nephritis and who are currently taking Lupkynis. It's designed to provide resources for the people who are living with the disease and their care partners. The program is completely staffed by all registered nurses who have significant experience in insurance and funding issues. So if you do enroll, you would be connected with a nurse case manager who would be dedicated to your needs throughout your entire treatment journey. These nurse case managers will help you learn more about lupus nephritis. Again, help you assist in navigating through the insurance and funding options for Lupkynis, and quite frankly, help you stay on track with your Lupkynis treatment. Now, these nurse case managers will not give medical advice, and they will direct patients to their healthcare providers for any questions or answers around disease treatment or referral related questions. And they are available Monday through Friday from 8 a.m. to 8 p.m. Eastern Standard Time. Next slide, please. So by enrolling in Aurinia Alliance, this will open the door for this dedicated support. Your nurse case manager, again, will partner with your healthcare team to help initiate you with your Lupkynis treatment and help you access everything the program has to offer, again, including additional resources, information about treatment, financial assistance, as well as working with your specialty pharmacy to ensure that you get your Lupkynis prescription filled. After you're connected with the nurse case manager, they will be with you every step of the way. Again, help you stay on track with your treatment. It is important to connect with your nurse case manager once you get started and learn the next steps. They will stay in contact with you throughout your treatment journey. So please add the following phone number at the bottom of your screen, 1-833-287-4642 or 1-833-Aurinia. Please put that on your phone so that if someone contacts you, spam or someone trying to sell you something, know that it is your Aurinia nurse case manager reaching out to help you with your Lupkynis and your journey with lupus nephritis.
So just to recap, some of the problems we discussed before that you should be aware of, which is why you need regular follow-up, that you need to monitor the kidney, the blood pressure. We spoke about some of the headaches, confusions that could be part of the lupus. Once you're on the drug, you have to be assessed. Frequent labs to check the potassium, any chest pain or palpitations, you need to report. And again, your blood scheduling to check of any anemia, that's very important. And any more side effects of the Lupkynis, a more extensive list is always there available. So I'm happy to answer any questions. Are there any?
Again, as a reminder, please type your questions into the chat box. We did have a question earlier on, Dr. Carr, with regards to, is anemia a sign that you may be progressing to lupus nephritis, or is it a sign of lupus nephritis?
So there are many types of anemia that can occur in patients with lupus, and it depends on that type. So if you have chronic renal disease, because the kidney produces something called erythropoietin that also stimulates the bone marrow to produce red blood cells. So if the kidneys are failing, you don't have that, and you could have anemia. So your physician will be able to look at the anemia and determine the type of the anemia, and from there determine the cause. So it could be part of failing kidneys, but there are other causes as well. Iron deficiency, for example, is another one. Immune-mediated hemolytic anemia, destruction of the cells, can occur in lupus. So it's the type of anemia, and your physician will be able to distinguish which one and give appropriate therapy.
Thank you. Any other questions in the chat box, please, again? Okay, here we go. Can recurrent UTIs be caused by lupus nephritis?
No, not usually. When you're on immunosuppressive therapies, there's always a risk of infection anywhere, but also the urinary tract. But the urinary tract, I think if you have frequent infections there, it's not unique to lupus per se, and that has to be evaluated separately to see if there's any potential obstruction that's occurring and anything going lower down in the system. But it's not part of lupus per se, but it has to be addressed because you don't want to have concurrent infection while you're treating lupus.
Okay, we have one question with regards to someone who is on 2,000 milligrams of Cellcept. I wanted to know, with lupus nephritis, is there a significant change in your dietary requirements or the diet?
So you'd have to discuss with your physician because I'm not sure what your renal status is in terms of stage of disease, and they'll be able to advise you on that. If it was specific to the dosing of the Cellcept, there's no dietary restriction with that. It's more the function of the kidney. And again, your nephrologist, rheumatologist will have to discuss that with you based on the function of the kidney.
Is there any way, or are there any symptoms that we would know to recognize that we might have the onset of nephritis or lupus nephritis?
So because we don't want you to have the clinical symptoms of nephritis, we mentioned some of that at the beginning with the testimonial, but also when we look at some of the symptoms, right? When you had swelling in the lower extremities, frothy urine, your blood pressure goes up. We want to be able to detect any renal involvement very early. The only way we can do that is regular, frequent screening of that urine. Every 3 months is to have that urine sample given so we can detect any proteinuria, any red blood cells, etc. in the urine. That's the best way. It's a microscope into the kidney, that urine, simply every 3 months. We don't want people to get symptoms because that's probably down the road, and that means you've lost a lot of renal function to get to those clinical symptoms. Let's detect it early by regular follow-up, looking at the urine.
Next question. Can you be in remission from lupus nephritis?
Yes, you can. And that requires treatment, whatever the physician thinks is best for you, getting you down to little or no proteinuria, blood pressure controlled, cholesterol controlled, you remain healthy and active, healthy lifestyle, that is controlled lupus. And the therapies that keeps you there, they can adjust to know how much you need, how much to pull back or not to maintain that normal function.
Is Lupkynis only available for adults?
Yes, that's the only current approval.
Are there any contraindications for using Lupkynis?
So not at present. You're not to use it in combination with any other drugs that may be used in lupus nephritis because it wasn't studied that way, like cyclophosphamide or any of the other immunosuppressives that we use. This was only used in combination with the mycophenolate.
Okay. I don't see any additional questions for you at this time, Dr. Carr. I do have one question that did come in the queue for Judith. Is Judith, are you still on the call? Oh, sorry, we can't ask Judith any questions. My apologies. Since her part is over, we'll get her answers to those questions through Amy and the Lupus Foundation. So at this point, we don't have any additional questions. Thank you, Dr. Carr, for your outstanding presentation. And thanks to everyone.
You're welcome. Thank you.
Yeah. You know, again, if you have any other questions or want more information after today's conversation, you can visit lupkindness.com. There you can learn more about, not only learn more about LupKindness, but you can get information about taking it, find answers to frequently asked questions, and much, much more. You can also find support resources at areniaalliance.com. And there again, you can learn more about the Arenia Alliance program and connect with a dedicated nurse case manager who can offer support again throughout your LupKindness treatment journey. And you can get started all by calling Arenia Alliance at 1-833-287-4642. Again, I'd like to thank you, Dr. Carr, for your excellent presentation tonight. And I'd like to thank everyone for sharing their time and insights with us this evening, and hope everyone has a terrific evening. Thank you.
Thank you, and thank you, Judith.
Thank you so much, Dr. Carr, Judith, and Steve, and for Arenia for sponsoring us tonight. And if you have any other questions, again, www.lupusfl.org for information and support services. Thank you and have a wonderful night.
Bye, everyone.